Welcome to this presentation on the anatomy and physiology of the airway. We'll explore the structures and functions of the respiratory system in depth, emphasizing their critical importance in the ICU. The airway is central to managing patients with respiratory failure, airway emergencies, or those requiring mechanical ventilation, common scenarios in critical care. My goal is to equip you with a robust understanding that you can directly apply to patient care. Let's dive in. Introduction to the respiratory system. The respiratory system is vital for life, performing several key functions. Its primary role is gas exchange, delivering oxygen to the blood and expelling carbon dioxide, a byproduct of metabolism. It also regulates blood pH by adjusting CO2 levels, which is critical in acid-base balance. The system protects against inhaled pathogens and irritants via mechanisms like mucus and cilia, and it supports vocalization, though this is less relevant in critical care. In the ICU, we often focus on oxygenation and ventilation, as respiratory failure, whether from ARDS, pneumonia, or airway obstruction, is a leading reason for admission. This presentation will connect these functions to your clinical practice. Conducting zone versus respiratory zone. The respiratory system is divided into two functional zones. The conducting zone includes all structures from the nose to the terminal bronchioles, which transport air but don't participate in gas exchange. These structures filter, warm, and humidify air to protect the delicate alveoli. The respiratory zone, starting with the respiratory bronchioles and including alveoli, is where gas exchange occurs via diffusion of O2 and CO2. This distinction is critical in critical care. Intubation bypasses the upper conducting zone, while mechanical ventilation supports the respiratory zone. Understanding these zones helps you target interventions effectively. Upper respiratory tract anatomy. The upper respiratory tract starts with the nose and nasal cavity, which filter out large particles like dust using hairs and mucus. These structures also warm and humidify air, optimizing it for the lower airways. The pharynx, a shared passage for air and food, has three regions: the nasopharynx, oropharynx, and laryngopharynx. Olfaction occurs in the nasal cavity, though it's not a focus in critical care. During intubation, the upper airway is bypassed, meaning its protective functions are lost, increasing risks like infection or dryness, key considerations in ventilated patients. The nasal cavity. The nasal cavity is a complex structure. The nasal conchae, three bony projections, create turbulence, increasing the surface area for air to be filtered, warmed, and humidified. The meatuses are the air passages between them. The olfactory epithelium in the upper cavity detects smells, while the paranasal sinuses, which includes the frontal, maxillary, ethmoid, and sphenoid sinuses, lighten the skull and aid voice resonance. In critical care, sinusitis from prolonged nasotracheal intubation or nasal cannula use can lead to infections, potentially worsening respiratory status. Recognizing these risks helps in patient monitoring and prevention strategies. Pharynx. Structure and function. The pharynx is a muscular tube with three regions. The nasopharynx, behind the nasal cavity, contains the adenoids, which are lymphoid tissue aiding immunity. The oropharynx, behind the mouth, houses the palatine tonsils and serves both air and food. The laryngopharynx connects to the larynx and esophagus. In critical care, the pharynx is significant during intubation, as the tube passes through the oro and laryngopharynx. Tonsillar enlargement from infection or abscess can obstruct the airway, requiring urgent intervention like intubation or drainage. Its immune role also highlights infection risks in ventilated patients. Larynx, the voice box. The larynx, or voice box, is a critical structure made of several cartilages. The thyroid cartilage is prominent as the Adam's apple, while the cricoid cartilage, a complete ring below it, is a key landmark for emergency tracheostomy. The epiglottis, a leaf-shaped flap, closes the glottis during swallowing to prevent aspiration, a vital protective mechanism. The true vocal cords produce sound, while the false cords above them help seal the airway. In critical care, the larynx is central to intubation. Prolonged tube placement can damage vocal cords, and laryngospasm can complicate airway management. Knowing its anatomy aids in these scenarios. Trachea, structure and function. The trachea, or windpipe, is a 10 to 12 centimeter tube supported by 16 to 20 C-shaped cartilage rings, which keep it open while allowing esophageal expansion during swallowing. The trachealis muscle, on the posterior wall, contracts during coughing to narrow the lumen, increasing airflow speed to expel debris. The lining, pseudostratified ciliated columnar epithelium with mucus-producing goblet cells, traps particles, and cilia sweep them upward for removal. In critical care, the trachea is the site for tracheostomy in prolonged ventilation, and understanding its structure helps manage complications like stenosis or mucus plugging. Bronchial tree, from bronchi to bronchioles. The bronchial tree begins with the primary bronchi, branching from the trachea into the lungs at the hilum. The right bronchus is shorter, wider, and more vertical, making it a common site for aspiration, crucial to know in critical care. Secondary bronchi supply each lobe, 3 on the right, 2 on the left, and tertiary bronchi serve bronchopulmonary segments, the lungs' functional units. Bronchioles lack cartilage, relying on smooth muscle, which can constrict in asthma. Bronchoscopy targets these airways to clear obstructions, and their anatomy guides chest imaging interpretation. Tracheobronchial anatomy. This slide outlines the tracheobronchial anatomy, detailing the airway from the trachea to the segmental bronchi. The trachea, supported by C-shaped cartilage rings, bifurcates at the carina into the main bronchi. The right main bronchus is shorter, wider, and more vertical, predisposing it to aspiration, while the left is longer, narrower, and more horizontal. Lobar bronchi divide into 3 on the right upper, middle, and lower lobes, and 2 on the left upper and lower lobes. Segmental bronchi supply the bronchopulmonary segments, with 10 segments per lung listed here. For the left lung, variations exist, typically 8 segments, but 10 are presented for consistency, reflecting common clinical usage. This anatomy is essential for understanding procedures like bronchoscopy and interpreting lung imaging. Terminal and respiratory bronchioles. Terminal bronchioles are the end of the conducting zone, delivering air without gas exchange. Respiratory bronchioles mark the start of the respiratory zone, with alveoli budding from their walls, initiating gas exchange. This transition is where ventilation and perfusion must align for efficient oxygenation, a key concept in critical care. Mismatches, like in pulmonary embolism or atelectasis, impair gas exchange, requiring interventions like PEEP or thrombolytics. Understanding this helps optimize ventilator settings. Alveoli, site of gas exchange. Alveoli are the functional units of gas exchange, organized into sacs and ducts. Type 1 pneumocytes, making up most of the alveolar wall, are thin for rapid diffusion of O2 and CO2. Type 2 pneumocytes secrete surfactant to reduce surface tension, preventing collapse, crucial in neonates and ARDS. Alveolar macrophages clear debris and pathogens. In critical care, alveolar damage from pneumonia or ARDS impairs gas exchange, necessitating oxygen or ventilation support. Protecting these structures is a priority. Lung anatomy, lobes and fissures. The lungs are divided into lobes by fissures. The right lung has 3 lobes, upper, middle, and lower, separated by oblique and horizontal fissures. The left lung has 2 lobes, upper and lower, divided by an oblique fissure, with a cardiac notch accommodating the heart. This anatomy is clinically relevant. Lobar pneumonia affects specific lobes visible on X-rays, and atelectasis, collapse, may require lobe-specific interventions, like bronchoscopy. Knowing these divisions aids in diagnosis and treatment planning. Pleura, protective layers. The pleura are double-layered membranes encasing the lungs. The visceral pleura covers the lung, while the parietal pleura lines the thoracic cavity. The pleural cavity between them contains a small amount of fluid, minimizing friction, and using surface tension to keep lungs inflated against the chest wall. In critical care, pleural effusions, fluid buildup, or pneumothorax, air entry, disrupt this balance, causing respiratory distress. Thoracentesis or chest tubes address these issues, making pleural anatomy essential knowledge. Blood supply to the lungs. The lungs have a dual blood supply. The pulmonary circulation carries deoxygenated blood from the right ventricle via the pulmonary artery to the alveoli for oxygenation, then returns it to the left atrium via pulmonary veins. The bronchial circulation from the aorta nourishes the lung tissue itself. In critical care, a pulmonary embolism blocks pulmonary arteries, impairing gas exchange and causing hypoxemia, a life-threatening condition requiring rapid diagnosis treatment. Innervation of the respiratory system. The autonomic nervous system regulates airway function. Parasympathetic fibers from the vagus nerve cause bronchoconstriction and mucus production, preparing the airway for rest or defense. Sympathetic activation dilates bronchi and reduces mucus, aiding airflow during stress or exercise. The cough reflex, mediated by vagal afferents, clears irritants. In critical care, beta agonists, such as albuterol, mimic sympathetic effects to relieve bronchospasm in asthma or COPD, while anticholinergics, such as ipratropium, block parasympathetic constriction, key pharmacological tools. Mechanics of breathing, inspiration. Inspiration is an active process driven by the diaphragm and external intercostals. The diaphragm contracts and descends, while the intercostals lift the ribs, expanding the thoracic cavity. This increases volume, dropping intrapleural pressure below atmospheric pressure, creating a gradient that draws air in due to atmospheric pressure being alveolar pressure. In critical care, mechanical ventilators mimic this by delivering positive pressure to inflate the lungs, reversing the natural negative pressure mechanism. Understanding this helps adjust ventilator settings for optimal lung expansion. Mechanics of breathing, expiration. Expiration is passive during quiet breathing. The lungs and chest wall recoil elastically, reducing thoracic volume and raising intraalveolar pressure above atmospheric pressure, expelling air. During exercise or coughing, internal intercostals and abdominal muscles actively compress the thorax. In critical care, patients with COPD have obstructed airways, making expiration active even at rest due to air trapping, leading to prolonged exhalation and dyspnea. This informs treatments like bronchodilators or pursed lip breathing. Pressure relationships in breathing. Breathing relies on pressure gradients. Atmospheric pressure is constant, while alveolar pressure fluctuates. It drops below 760 millimeters of mercury during inspiration to draw air in and rises above during expiration. Intrapleural pressure stays negative due to lung recoil versus chest wall expansion, preventing collapse. Transpulmonary pressure is the difference driving lung inflation. In critical care, positive end expiratory pressure, PEEP, on ventilators maintains transpulmonary pressure, keeping alveoli open in conditions like ARDS, crucial for oxygenation. Lung compliance and resistance. Compliance measures how easily lungs expand, high in healthy lungs, low in stiff conditions like fibrosis or ARDS, requiring higher ventilatory pressures. Resistance reflects airflow ease, low in wide airways but high in narrowed ones, such as in asthma. In critical care, low compliance may need higher PEEP, while high resistance calls for bronchodilators. These properties directly influence ventilator adjustments to balance oxygenation and lung protection, avoiding overdistension or collapse. Lung volumes and capacities. Pulmonary function tests can be performed to assess respiratory volumes and capacities. Respiratory volumes quantify lung capacity. Tidal volume is the air moved in a normal breath, about 500 milliliters. Inspiratory reserve volume and expiratory reserve volume are the extra air you can inhale or exhale with effort, while residual volume is what is left in the lungs to prevent collapse. Capacities are certain volumes added together. For example, total lung capacity is the sum of the inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. Vital capacity, maximum air exhaled after a full inhalation, is the sum of the inspiratory reserve volume, tidal volume, and expiratory reserve volume. Functional residual capacity is the air left after a normal exhale, and inspiratory capacity is the maximum inhalable volume. In critical care, reduced vital capacity or total lung capacity suggests restrictive disease, such as fibrosis, while an increased functional residual capacity may indicate air trapping, such as in COPD. These metrics guide diagnosis and management strategies. Control of ventilation. Ventilation is controlled by brainstem centers. The medulla's dorsal group sets the basic rhythm, while the ventral group boosts effort during demand. The pons pneumotaxic center limits inspiration, and the apneustic center prolongs it. Central chemoreceptors detect CSFCO subscript 2 and pH changes, while peripheral ones located in carotid and aortic bodies sense blood, O subscript 2, CO subscript 2, and pH. In critical care, these controls influence respiratory drive, key for weaning patients off ventilators, as intact responses indicate readiness to breathe independently. Gas exchange principles. Gas exchange relies on diffusion across the respiratory membrane, driven by partial pressure gradients. Alveolar PO2 is around 104 millimeters of mercury and exceeds venous blood, PO2, which is around 40 millimeters of mercury. So O2 diffuses into the blood. CO2 moves from blood, which is around 46 millimeters of mercury, into the alveoli, which is around 40 millimeters of mercury. The membrane, which is only 0.5 micrometers thick, includes only type 1 pneumocytes and capillary endothelium for optimal diffusion efficiency. There are many conditions that thickens this barrier, reducing diffusion and causing hypoxemia. Oxygen transport in blood. Oxygen is mostly transported bound to hemoglobin, approximately 98.5% saturated, with a small fraction dissolved in plasma. Each hemoglobin molecule has 4 subunits, each with an iron-containing heme group that binds one O2, allowing up to 4 O2 per hemoglobin. In critical care, low hemoglobin reduces oxygen carrying capacity, worsening hypoxemia. Monitored via labs, and treated with transfusions if severe. This is why oxygen saturation alone isn't enough. You need HB levels too. Oxyhemoglobin dissociation curve. The oxyhemoglobin dissociation curve shows how O2 binds to hemoglobin based on PO2. Its S shape reflects cooperative binding. At alveolar PO2 of approximately 100 millimeters mercury, hemoglobin is 98% saturated. At tissue PO2 approximately 40 millimeters mercury, it's 75% saturated, releasing O2. A right shift, as with acidosis or fever, unloads O2 to tissues, which is common in sepsis, while a left shift, as in hypothermia, retains O2. In critical care, this curve explains oxygen delivery dynamics and guides therapy in metabolic or respiratory distress. In summary, a leftward shift in the curve is caused by decreased temperature, decreased 2,3-DPG, alkalosis, and carbon monoxide. This results in an increased affinity to oxygen, causing the hemoglobin to hold onto O2. A rightward shift in the curve is caused by increased temperature, increased 2,3-DPG, and acidosis. This results in a decreased affinity to O2, resulting in oxygen offloading. Carbon dioxide transport. CO2 is transported in three ways: dissolved, which is minimal, bound to hemoglobin as carbaminohemoglobin, and mostly as bicarbonate. In red blood cells, carbonic anhydrase converts CO2 plus H2O to H2, CO3, which dissociates into H plus and HCO3-. HCO3 exits via the chloride shift, balanced by Cl entry. In critical care, CO2 levels, measured via PaCO2, indicate ventilation adequacy. High in hypoventilation, seen with respiratory acidosis, and low in hyperventilation, as with respiratory alkalosis. Causes of hypoxemia. There are 6 primary causes of hypoxemia, low oxygen in the blood, a vital concept for diagnosing respiratory issues. The slide splits these causes into 2 groups based on the AIA gradient, normal and elevated. The AA gradient tells us if the problem is oxygen delivery to the alveoli or its transfer into the blood. Let's talk about cases of hypoxemia with a normal AA gradient. First, we have low-inspired O2 content. This is a rare cause of hypoxemia, but it can happen in situations like high altitude, where the partial pressure of oxygen in the atmosphere is lower. Think of climbers on Mount Everest. They often need supplemental oxygen to compensate. It's not something we see often in typical clinical settings, but it's worth considering in specific scenarios. Next is alveolar hypoventilation, which occurs when a patient isn't ventilating adequately to bring enough oxygen into the alveoli. This can happen due to mechanical restrictions, like trauma to the chest wall, or neuromuscular issues, such as in Guillain-Barré syndrome or myasthenia gravis. It's also a common issue in obstructive lung diseases like COPD, where air trapping reduces effective ventilation. In these cases, the AA gradient remains normal because the problem is upstream of the alveoli. The third cause under normal AA gradient is low mixed venous O2 concentration. This happens when the oxygen content in the venous blood returning to the lungs is abnormally low. It's typically seen in conditions like severe anemia, where there aren't enough red blood cells to carry oxygen, or low cardiac output states, like in heart failure. High O2 utilization, such as in septic shock, can also contribute. Here, the issue isn't with the lungs themselves, but with systemic oxygen delivery. Now for causes of hypoxemia with an elevated AA gradient. The most common cause of hypoxemia is ventilation perfusion, or VQ mismatch. This occurs when there's an imbalance between air reaching the alveoli and blood flow to those alveoli. Think of conditions like obstructive lung diseases, such as asthma or COPD, or pulmonary vascular diseases like pulmonary embolism, where blood flow is blocked. It can also happen with alveolar filling processes like pneumonia, pulmonary edema, or interstitial lung disease. Even atelectasis, where alveoli collapse, can cause V to Q mismatch. This is a broad category, so it's often the first thing we consider in hypoxemia with an elevated AA gradient. Next is shunt, which can be anatomic or physiologic. An anatomic shunt occurs when blood bypasses the lungs entirely, like in congenital heart defects such as an atrial septal defect, ventricular septal defect, or an arteriovenous malformation. A physiologic shunt happens when blood passes through the lungs but doesn't get oxygenated, as in atelectasis, ARDS, or pulmonary edema. A key point here: shunts do not correct with supplemental oxygen because the blood isn't reaching ventilated alveoli. Also, be aware that medications like nitrates and calcium channel blockers can worsen shunting by causing vasodilation in poorly ventilated areas. Finally, we have diffusion limitation, where oxygen struggles to cross from the alveoli into the bloodstream. This is often due to thickening of the alveolar capillary membrane, as seen in pulmonary fibrosis, or due to fluid and inflammation, like in pulmonary edema or severe infections. Diffusion limitation is less common but important to consider in chronic lung diseases. In summary, understanding these 6 causes of hypoxemia equips us to pinpoint the root of oxygenation issues and tailor effective treatments for our patients. Respiratory acid-base balance. The respiratory system regulates pH via CO2. Hypoventilation raises PaCO2, forming carbonic acid and lowering pH, seen in opioid overdose or COPD as examples. Hyperventilation lowers PaCO2, raising pH, common in anxiety or early sepsis. Kidneys compensate by altering HCO3 over hours to days. In critical care, arterial blood gases diagnose these states, guiding ventilatory adjustments or bicarbonate therapy to restore balance. Modifications in respiratory functions. The respiratory system adapts to demand. Exercise/stress increases ventilation to meet O2 needs, driven by CO2 and H+ detection. At high altitude, hypoxia boosts ventilation and red blood cell production via erythropoietin, compensating for low PO2. In diving, breath holding raises PCO2, triggering breathing, a protective reflex. In critical care, these adaptations explain patient responses to hypoxia or exertion, guiding oxygen therapy or ventilator settings in stressed states like sepsis or trauma. References. That about wraps things up for now. Thank you for joining me on this long journey through the airway's anatomy and physiology. I hope this brief exploration has helped build foundation for your critical care role. These references provide a deeper dive into the topics covered. OpenStax offers a solid foundation, while UpToDate and journal articles give clinical insights. Use them to expand your knowledge or clarify complex points as you grow in your critical care practice.